Good morning, everyone. Sorry we're getting started a little bit late, but with the weather, we wanted to allow time for people to get in since there were lines at the doors this morning. So my name is Christine Leonard. I'm the director of the DC office for the Vera Institute of Justice, and I want to thank all of you for taking the time to come this morning during recess, and especially on a horrible rainy day, although I think we should be grateful it's not snow, I guess. Just to start off, we, as some of you know, and it's nice to see some of you again, have been in the middle of an effort to have a series of briefings around the state of juvenile justice and what we're titling a national conversation around research, results, and reform. We started in September and had an opening event with the film Kids for Cash. If you've not yet seen it, it's a great opportunity to learn more about an incident that happened up in northeastern Pennsylvania where thousands of young people were detained and later found to have perhaps, in many cases, not engaged in any illegal activity, but there was a situation there where two judges were receiving kickbacks for detaining youth. So film's very powerful. I highly encourage you to see it. It exposes a lot of concerns around fairness and justice, not only in Pennsylvania, but the needs for kids to have appropriate systems in place when we all make mistakes. And also at that briefing, we had the fortunate opportunity to hear from Dr. B.J. Casey, who's one of the most renowned brain scientists around adolescent brain development. And she talked a lot about the fact that all of us go through this period of adolescence where the thing we all have in common is that as teenagers, you're highly influenced by your friends and perhaps make some unwise choices. And I think one of the things that we're really trying to highlight during this series is, you know, what should happen at a point in a youth's life when some of those events occur, and what happens if, in fact, during those situations they have contact with our criminal justice system. What are the kind of consequences that should ensue? So we had our first series briefing on status offenses, where we heard from youth as well as experts on what status offenses are. These are often activities that are non-criminal in nature, like truancy or runaways, or other school referrals that bring kids into contact with the justice system. And that was followed by a briefing on youth risk assessment and needs tools. For those of you that may have missed some of those, as of, I think, early next week, we will have excerpts of all of the briefings as well as the materials for those events on our website. But I'm particularly glad that you're here for this morning's discussion, because this is really the briefing that I have most looked forward to, which is about what happens with kids with mental health or behavioral health issues who come into contact with our youth justice system. And this is a topic that, you know, we really have some of the best voices in the country to come and speak about today. I also just want to highlight that thanks to Krista Larson, who is our acting director at Vera Center on Youth Justice, we have a fact sheet for you that highlights some key facts that we're releasing today. The other fact sheets from our prior briefings will also be on our website. But if you just even take a moment to take a quick glance at some of the top statistics, more than 2 million youth and young adults come into contact with the juvenile justice system each year. And up to 70% of these young people have been diagnosed with at least one mental health disorder. That's a pretty sizable portion of the population. And we've known about this concern since 2004, when the House of Representatives Government Reform Committee did a report that found that 2/3 of youth in juvenile detention facilities across the country reported holding youth because they needed mental health treatment not available in their communities. So it's really important to think about that. If you're a family in this country and your child is having a mental health crisis, more often than not, in 2/3 of these situations 10 years ago, people were finding that they had to bring their young person into a detention facility in order to get them assistance for a mental health issue, not because they had some other kind of activity going on. And surely, you know, there can be situations when, as we'll hear from Sheriff Stanek later today, where the crisis can elevate and perhaps there is intersection with the criminal justice system for other reasons. But at the core, we're talking today about kids who have mental health diagnoses. It's really important, I think, for all of you in the congressional offices that you represent to be able to think about what this issue means locally within your communities, what role the federal government can play in terms of helping to solve these challenging issues, and also just at the end of the day, to be very aware of the fact that kids who come into contact with the criminal justice system may be there for reasons beyond their control. Perhaps they have early signs of mental health issues that have not yet been diagnosed, or perhaps they just don't have the resources to get the help that they need. And I think that the most important part of the conversation that we'll be able to have today is what can we do better as a country to make sure that these resources are available to young people before it becomes a crisis situation that has happened in just even recent memory in this past year in Newtown, Connecticut, Columbine. I mean, you can think about the places that we all have come to know because of horrible tragedies that have resulted from these types of situations where kids aren't getting the kind of help and services and support that they need. So again, I thank you for being here. I'm going to take a brief moment to just introduce our very distinguished panel and then turn it over to them for their presentations. But I'm really thrilled to have Dr. Joe Kokoza here today. We first met when I was a desperate staffer working on the Senate Judiciary Committee in search of good facts and evidence around these issues. And I tracked down Joe on the internet, and thankfully he took my call then and still talks to me close to 8 years later. His position is the Director of National Center for Mental Health and Juvenile Justice, which is located within the Policy Research Associates, Inc. He's also the Vice President of Research there. He's worked on a number of projects. I mean, if you do any Google searches, his name will pop up quite a bit as the sole authority on this topic. But he has really led the field, I think, in a number of ways in terms of the research that he's done, as well as his number of publications. Dr. Kokoza holds a doctorate in sociology from Case Western Reserve University, and he also is the author, as I mentioned, of a number of publications and reports, many of which we have here for you on the table outside, along with a series of briefs that were produced by the MacArthur Foundation around this particular topic. To his right is Sheriff Richard Stanek, who is the Hennepin County Sheriff. We're very happy that he was able to travel to join us here today. Prior to that position, he was elected into the Minnesota House of Representatives, where he served from 1995 until 2003. In 2003, he was appointed to serve as the Commissioner of Public Safety and Director of Homeland Security, where he stayed until 2004. Prior to that, he's got a long career in law enforcement. He was first in the Minneapolis Police Department in 1986. And really has stayed to dedicate his life to work around these issues in public safety. He's been the sheriff of Hennepin County since 2006, and somehow in his spare time still finds opportunities to be a volunteer in his community, where he works with community-focused organizations working with youth. Sheriff Stanek graduated from the University of Minnesota with a bachelor's degree in criminal justice and got his master's in public administration from Hamline University. And then finally we have Dr. Walker, who is currently a research assistant professor at the University of Washington Department of Psychiatry and Behavioral Services. She has been extensively involved in the Models for Change initiative, where she has been engaged in numerous conversations, both in Washington but across the country, around these particular intersection of kids with mental health issues, but also best practices and policies that can result from that. A major theme of the work that I think she will talk about today is adapting research-based interventions and as well to meet the specific needs of those who will need it. And I'm very excited that she'll also be able to highlight a lot of her work around gender-specific programming for girls, the importance of family in developing policies for youth, as well as mental health treatment and diversion programs. Dr. Walker received her doctorate in counseling psychology at the University of Southern California. She completed her residency at the West Los Angeles Healthcare Administration, and then again, very determined, completed a postdoctoral fellowship at the University of Washington in the Division of Public Behavioral Health and Justice Policy. So as I said from the beginning, we're really privileged that during this point where we hope we can have a really live dialogue with all of you to be able to bring these folks from different parts of the country who really are the top leaders around this topic. And I just want to take a moment to thank the support that the Vera Institute of Justice has gotten from the MacArthur Foundation in order to do this series of briefings. It's really a tremendous opportunity for us to be able to bring these conversations to the staff and other colleagues working on these issues in Washington, D.C. And lastly, I'll just say that I also want to acknowledge, especially on this very rainy day, my colleagues at Vera, especially Sarah Schmitz, who's the Associate Director of our DC office, Libby Love, who's here in the back, who runs our office, who have been just tenacious and diligent in getting these events off the ground and running smoothly. But also, as those of you in DC can appreciate, we couldn't do any of this without a stellar group of interns. And we have Abby with us here today. And I just want to thank you all for making it happen that we could be here for this conversation today. So with that, I'm going to turn it over to Dr. Kokoza. And again, each of them will give their remarks, and then we'll have some time for questions and answers at the end. Thank you.
Good morning, everyone. Good morning. Thank you very much for the nice introduction, and I hope we get a chance to work together for not just another 8, maybe another 28 years or something. I'm Joe Kokoza. I'm the director of the National Center for Mental Health and Juvenile Justice. We're based in upstate New York, just outside of Albany, and if any of you really feel as though you need some snow, you're welcome to come visit us at any time. I've got a tough task in front of me. My job is to kind of give you an overview of why this is an important issue, what some of the critical questions are, and in particular, and I think most importantly, to talk a little bit about the changes and significant trends that are occurring both in general in juvenile justice, as well as in particular in juvenile justice with regard to the large numbers of youth who have behavioral health issues. And then to talk about some of the things that would be nice if we could all do, and to do all of that in a little bit over 10 minutes. So luckily I talk quickly, and also luckily we run, as I said, the National Center. I'll give you the contact information, our website at the end, and please feel free as any of you and your interest gets piqued in this, or your principals decide they really want more information, please don't hesitate to give us a call or contact us, okay? Please. So I'm not gonna, it's funny because the screen's up there. There are also copies of the slides out front, so hopefully, because I'm gonna go through them quickly, I'm not gonna read everything that's up there. So as I said, we're based in upstate New York, and we established ourselves in 2001 for a very particular reason. One, because of the growing awareness of the large numbers of youth who have behavioral health disorders in the juvenile justice system. And secondly, the fact that there was no place that anyone could go to, no single place anyone could go to get information. And as we traveled around the country dealing with this issue, we would find someone dealing with a problem in Indiana, and then the next week we'd be in Washington State, and the next week we'd be in Texas, and then we'd be in New Jersey. And that over and over again, the same issues were coming up. People were coming up with creative solutions, but there was no way for them to find out what anybody else was doing. So a lot of what we do is really try to stay on top of what's going on in the field. We do some research, some evaluation, but a lot of the work that we do now is really in terms of providing training, technical assistance across the country. And just so you know, if you're using a stopwatch on your phone, it doesn't work if you don't hit start. Okay. Yeah, I want to, just a little bit, please. Christine mentioned Models for Change, and I just want to let you know, we, in terms of giving us a sense of what we do over the years, we've worked in our organization heavily supported with federal funds from OJJDP, I assume people know the acronyms, or SAMHSA, We also do a lot of work with states and local jurisdictions, particularly around helping them to develop strategic planning or implement programs. But for the last 10 years or so, we've been working very heavily, and a lot of our work has been in conjunction with something called Models for Change, which is a major initiative that was developed by the MacArthur Foundation. I'll give you the website at the end for this as well. MacArthur Foundation, to really try to bring about juvenile justice reform in the country. And they approached it by working with initially a relatively small number of states and communities across the country and trying to bring in their funding, which was substantial, as well as leading experts in a variety of areas, such as mental health, to really work with those states to bring about significant reform. It has been extremely successful, and a lot of what I'm going to talk about later on comes from the work from Models for Change, and that work has continued to spread through some joint activities with some of the federal agencies. The other thing I do want to mention is, as part of that, the foundation decided that they really wanted to work on getting the message out and getting the information out. And so they set up 4 resource centers. We run one of them called the Collaborative for Change. There are 3 others, one dealing with kids who are involved with both the child welfare and justice area, one focusing on racial and ethnic disparity, and one focused on screening. And Gina Vincent was part of this, and she's involved in one of those 4 resource centers. So that's background on all of that, please. So let me just talk a little bit about the numbers, and they're very much overwhelming. So somewhere between 60 to 7%, I'm not going to read all of them, of the kids in the juvenile justice system meet the criteria for at least one mental health disorder. Okay. Most of those kids have multiple disorders, and probably one of the most important ones is they also have substance use issues. And so that frequently in the literature we now talk about co-occurring mental health substance use issues, but it's so frequent that we now talk in general about behavioral health issues. And the assumption in most places now where most of them are moving toward is assuming that kids have both of those, and that to adequately respond you need to deal with both of them. We just finished a series of publications on co-occurring disorders as it relates to drug courts for the National Council on Juvenile Family Court Judges. So it's a thing that people are becoming aware of. The two important things I want to just emphasize are, first of all, one of the questions is, well, if it's everybody, then there's really nothing we can do, and how many of those kids are really seriously ill? And so while those kids meet criteria for mental health disorders, some of them do not necessarily need immediate help, significant help, they just need some help. But based on a series of other criteria, we estimate that roughly 25%, so at least 1 out of every 4 kids in the juvenile justice system, have a serious enough disability that they could as easily be in the mental health system. Okay, that's significant. The other thing I want to emphasize, and I suspect all of you know about this already, is the growing understanding and the importance of trauma and the role that it plays. The Attorney General here at the federal level did the report on defending childhood and children exposed to violence. We're doing some work right now following up on that with a number of states. But terribly important issue, we're beginning to understand that in addition to dealing with what's traditionally seen as mental health and substance use, it's critically important to bring trauma in. Sarah and I were just in Chicago last week. We ran a meeting where we're working with a number of states, and that's one of the things in terms of training, screening, that we're really trying to work on. Okay, and again, there's other numbers up there, high risk of suicide, those kinds of things. Okay, so the issues are fairly straightforward and fairly clear. The first one is most of these kids don't belong in the juvenile justice system. Okay, most of them are experiencing behavioral health problems. And when you get out there in the field and you talk to the judges and you talk to law enforcement, and particularly when you talk to family members, for the most part, the understanding is most of these kids have not done something seriously wrong. And again, there's some data up there that supports that. It's that we don't know what else to do with them. And so when you talk to family members who say, I literally have contacted 80 different agencies because my kid is acting funny, there's clearly something wrong, and he needs some kind of help, and I can't get any help, what do I do? One of the best examples of the level of frustration of family members actually came from a focus group that we were doing with family members. And these are the words of the mother, okay, who said, I talked to all my friends, people I knew who had kids who were experiencing problems, and went through the same frustration I did, and here's what they told me to do. They said, what you ought to do is get the kid involved in the juvenile justice system. File a status offense, pins, chins, fins, call different things, against your child, saying they stay out late. They're incorrigible, whatever the criteria is in your state, and then you get them in the justice system. She came back and she said, well, it's kind of a progressive state, and I filed those charges, but all they want to do is keep them back home and not without any services. So she said, okay, here's the next thing to do. Take a $20 bill out of your wallet or pocketbook, leave it on the kitchen table in the morning, go to work, come home, the kid will probably in all likelihood have taken the money, then you can charge him with a more serious crime, and then the justice system has to take him, okay? Very, very clear indication that most of these kids don't belong. At the same time, the juvenile justice system has become the system of last resort. It wouldn't be bad if the juvenile justice system was in fact the mental health system. It's not the mental health system. And when you talk to the commissioners, the directors who run these agencies, they talk about this is not our job, this is not our expertise, this is what we're trained for. Our responsibility is to care for and provide services and to protect the public for those kids who have committed serious crimes. These are not the kids that are our responsibility, and in fact, they should not be here. Okay. So I'm going to do quick 1,000-year history to give you a general sense in terms of the trends going on in the country, and then back to particularly the behavioral health piece. One of the things that's absolutely critical to understand is the incredibly significant changes going on in the juvenile justice system right now. They often talk about the different waves in juvenile justice. So 1899 was the first juvenile court, recognized kids are different from adults, we need separate courts. In the 60s, we had another period characterized by an emphasis on due process, where, quoting one of the judges reviewing all of this, said, it's the worst of both worlds. We neither provide them services, nor do we give them any protections. And so there was a major decision called in Ray Galt that said that kids ought to have access to lawyers and things like that. Third wave, which is most of us still kind of have our foot in, is the increasing crime rate, and particularly violent crime rate, late 80s, early 90s, and the incredible response. I mean, talk about dissemination and diffusion. Within a short period of time across the country, all the states went forward and allowed you to keep kids in longer, take them in younger, move them over to adult courts, all of those kinds of things, okay? We're now in what's called the fourth wave, partially as a result of the fact that we learned that that third wave did not work. Okay, there's lovely research out there that says you take kids, same background, same crimes, all those kinds of things, put them in the adult system, put them in the youth system, guess what? Who does worse? Much more likely to recidivate, much more likely to get involved in crime. But we also have excellent data that now says, also if you just put a kid in residential services, it also doesn't work terribly well. Okay, the recidivism rate across the country roughly is 75% of the kids who go into the deep end facilities come out, reoffend within 3 years. Okay, so wave 4 has been, the emphasis has been on better developmental understanding of youth. A lot of it's come out of the brain research, and again, Christine mentioned this a little bit earlier. So what the new research says, if you take, and I'm not a medical person, but if you take a look at the brain and there's different parts of the brain, that part of the brain that says, that looks like an awful lot of fun. It would be nice to be a little bit risky. We ought to do something like that, okay? It develops first, and then that other control center that sits someplace else in the brain that says, wait a second, you got to think about it. What are the consequences? What might happen if you do it? That develops much later. So very nice research that basically says what we all know, kids are kids. And we all have done stupid things as adolescents. But this shows that it's this biologically rooted in terms of and explained in terms of the development of the brain. Incredibly significant impact. So in 2005, 2010, 2012, major Supreme Court decisions that said kids are kids and they're different from adults. And so as a result of that, the first one said, we got to ban death penalty for kids under age of 18. No longer can you do that, okay? Second one said, not only that, we should not be requiring life without parole for anyone under 18 except in the most serious cases like homicide. The third one said, even if it's murder, homicide, they're still kids. You cannot do mandatory life without parole because kids change and we ought to give them a chance, even if we have to put them away for horrible crime, to view them as things that can change and things that can get better. A lot of that very much coming out of kind of this development approach, emphasis on data-driven, emphasis on outcomes, and custody and security, but at the same time with positive outcomes. Don't jump in, okay? The other piece that's happened, though, so that's kind of the 1,000-year piece. The other thing that's happened more over the past couple of decades is the incredible improvement of what we can do with kids who have behavioral health issues. So when I started in this business a lot of years ago, there was no instrument. There was no screening instrument. And so if you'd say some of these kids have mental health problems, they'd say, I don't know. Or I asked them a question and maybe. There's now absolutely outstanding screening instruments that are available in the field. You don't need to know the names of them, that help states identify which kids have behavioral health problems. There are over 40 states now using just one instrument, something called the MAISY, as a screening instrument to identify those kids who have behavioral health issues. As importantly, we now know, and you're going to hear a lot more about this in a minute, we now know that there are things that work. So again, when I was younger and you reviewed all of the literature, you always read the same thing. Massive review of all the literature on juvenile delinquency shows that there's no program that works. Okay? All that has changed through something called evidence-based practices. Again, I'm not going to talk much because you'll hear a lot more of this from Sarah, but we can now show you if you do this and you do it right and you do it with fidelity, then in fact your outcomes are better than other things. And all that other stuff that we've been doing maybe works, maybe doesn't work, but we don't have any idea. So we're pumping a lot of money into things we have no idea works, whereas we now have things that work. The other thing that's happened is, as a result of all of this, is a significant reduction of the kids in the deep end of the systems, the detention correctional. When I started in the business and put up a slide, we would talk about 110, 120,000 kids in detention correctional facilities each year. 60. Every time we do a presentation, we keep knocking the number down. Many states have now cut down the number of kids in the deep end by 50%. Okay, just think about it. 50% fewer kids in the deep ends where we were paying $100,000 to $200,000 a year for their care, no longer there. Oh, I got to do one more on that slide. So one of the things, particularly for the behavioral health kids, is an emphasis on diversion. So as part of this MacArthur work, we worked with 8 states. Each state included the commissioners of juvenile justice, mental health, substance abuse, family court judge, a family member, all kinds of things. First thing we did was we pulled the 8 states together and we said, what should we do? If we're focusing on kids who have mental health, substance abuse issues, what's the most important thing that we can do as a group that would then provide information to the rest of the country and guidance to the rest of the country? They did 3. I'm going to talk about the first 2. Number 1, the single most important thing, these are, again, the people who are running the systems. Most important thing that we can do, keep them out. They don't belong there. The best thing we can do, it's important to provide them services where they're in and the kids that are in, but the most important thing to do is to keep them out. And keep them out as early as possible. And as a result of that, we worked with those 8 states to develop 3 different approaches focused on the early points of contact of kids where you can most easily and appropriately divert them. One of them was schools. And so we all know about zero tolerance. We all know about the pipeline, all of those kinds of things. The first thing was we got to do a better job keeping them out. Develop outstanding models in Connecticut and Ohio and spreading elsewhere. And one of the pieces of paper out there is a review of what we've been able to do, showing all of the outcomes that we want, okay, but keeping those kids out. Second was law enforcement. And there's something called, and you'll probably hear a little bit more about this in a minute, crisis intervention teams that have been around for a long time, and it's training law enforcement officials about how to better deal with mental health, people exhibiting mental health issues. And when the 8 states said, we have that, what we don't have is information focusing on youth. That the CIT curriculum tends to focus on adults primarily, with a very little bit of it focused on juveniles. We developed an 8-hour curriculum that's now being added on as part of the CIT training in schools. So in one of the states we're working on, they're now developing, instituting CIT and CIT-Y, the youth piece, in the regionally across the entire state, okay? The third one was probation. Keeping the front end, again, this is all pre-adjudication, if you know the language, all very early on. Keeping the kids out, we develop a specialized behavioral health program down in Texas that's been outstanding. Just got to the point where when you get enough evidence, they call it a promising program, just got recognized by a national organization for the work it's doing. There's some discussion in Texas about getting that approved at the state level to expand throughout the entire state. Keeping the kids out of the system was seen as one of the most important things, keeping them out as early as possible. And part of what, why don't you go to the next one? And part of, because my time's running out, and part of what is very important, what I really want to emphasize in terms of this is an appropriate time for action, and there's a lot of things that we can do that you can see on the next slide. But one of the things that characterized all three of those pieces, and the piece that we're still doing a terrible job on, is making sure that the systems are working together. We still don't have mental health working in most cases. All three of those diversion programs that I mentioned, a key piece of making them work was getting the local mental health provider on board, so that when the law enforcement official says, this is not a kid that I ought to be dealing with, it's a kid that needs behavioral health services, that there was somebody that could step in and there was someone that they could contact. When we do the school diversion program, instead of the school resource officer or the school saying, we'll get zero tolerance, but this kid has behavioral health, but we don't know what to do with him, there's an emergency response team that goes out to the school and works immediately with the kid and the family. We're not doing a terribly good job of We're doing a good job of getting the kids out in the community. We're doing a good job of identifying who they are. We're not doing a very good job about making sure that they get the services they need. And many of you are young in this room, but you may recall we went through this with mental health on the adult level and closed all the facilities, moved all the kids out, all the adults out, and said, don't worry about it, we'll get the services for them. And now we're seeing, in terms of the homelessness and jails and everything, it didn't work. So there's a lot of other recommendations that I have up there that we're more than happy to talk about later on. But it is a very nice time to take some action because of the major changes and major advances. And there's the website for the National Center, for our particular resource center, and for Models for Change in general. Thank you all very much.
Thank you, Joe. So, Sheriff, I don't know, you want to go to the podium or here, whatever you feel most comfortable with. But I just wanted to acknowledge, as Joe said, we have his PowerPoint outside, so if you need any of those references or the websites, no need to take copious notes. We'll have those for you as well at the end. And now I'll turn it over to the Sheriff. Thanks.
Perfect. Well, thank you very much. That's loud, isn't it? Usually don't have, my voice is usually pretty loud, so if too much, let me know and I'll tone it down. Fair enough. Hey, well, good morning and thanks for having me here. There are a couple of handouts out in the hallway as well, and there's two of them that we'd written over the past couple of years about mental health. One focused specifically on guns. The other one was about the crisis that we're seeing in our jails. Christine told you that, you know, my name's Rich Stanek. I'm a sheriff in Hennepin County, Minnesota, the Minneapolis, St. Paul metro area. I run a county of about 1.2 million folks. And we've got about 800 folks in our agency, maybe 1,100 total. And we do a lot of work in public safety. So my perspective is from that aspect. We go to the second one. We primarily do 8 distinct lines of business in our sheriff's office, what is a full-service law enforcement agency in this country. I'm here on behalf of the Major County Sheriff's Association, those 80 or so largest sheriff's offices across this country, representing over 100 million of the nation's population. So let me take just a minute and tell you about what we provide. Most of our local police departments in your jurisdictions and in mine across the country usually provide 2 or 3 of these different lines of business, maybe just the jail, maybe just the courts, maybe 911 patrol. Many of the Major County Sheriff's Association provide all 8 of these lines of business and what you traditionally would see with a local law enforcement agency. Now, within the county, for those lines of business provided by the local police, we normally provide that for them. Our jail is the largest pre-adjudication facility in the upper Midwest. And when I say pre-adjudication, means we hold them until they are adjudicated by the courts. Many detention facilities or jails run by the sheriff's offices across the country hold both pre and post adjudication. We only hold them until they go to see the judge, and the judge determines a finding in terms of what they're there before the court for. If guilty, they'll go out to maybe one of the county's workhouses and/or state prison system, or back out into the community on probation. Our average length of stay is about 7.5 days per inmate. We book about 40,000 people a year through the front doors of our jail. And we guesstimate conservatively, just in my facility, that about 1/3 of those inmates suffer from mental illness, treated or untreated. If you go to Cook County, Chicago, if you go out to Los Angeles, California, those sheriffs will tell you that upwards of 60, 70+% of their inmates suffer from mental illness, treated or untreated. But keep in mind, they also hold after adjudication. We only do the pre-adjudication piece, and we have a fairly conservative number. And go to the next one. We said this a number of times before, and you heard this just referenced, that a jail is no place for the mentally ill. Certainly the Center for Disease Control reported that 1/4 of all the adults in the nation will suffer from mental illness in any given year, or about 60 million people. That's a lot. It's not any less true in our jail. Like we said, about 30% of our folks incarcerated in our jail every year suffer from mental illness. Think about, if you guys are all fairly young, hopefully you haven't had an experience staying in jail. Any of you been in jail recently?
That's a good crowd.
Well, I didn't think you would raise your hand. But think about it from this perspective, right? The jail, confinement setting. Look, you've got noises, you've got rules you got to follow, right? You've got people in uniforms, our deputies and others. You've got other folks in the jail. Not all of them are in the best of mood when they came to jail. Not all of them are totally innocent of what they're there for. And so those who are in our jails and suffer from mental illness, their conditions are exasperated, right? They are a danger not just to our staff, but to the other inmates. They are some of the most vulnerable people in our jail system. Other inmates take advantage of them, and unfortunately, sometimes they take advantage of themselves. Our sheriffs across this country deal with a number of suicides and critical emergent incidents within the confinement facilities of our jails because these folks suffer from mental illness. And at the end of the day, what you're going to hear me say over and over and over again ad nauseum is that the jail is not the place for those who suffer from mental incapacitation, right? We run a detention facility. We don't run a medical facility. I don't run an educational facility. I don't run a treatment facility. I run a detention facility. That's what you expect law enforcement and your county sheriffs to do. And so when we get these high numbers of folks who come into our jail setting, we're trying to figure out, well, what got them there to begin with? How do I get them back out on the other end, right? These are all questions that you've been dealing with over the last several meetings that you've had, and hopefully in some of the meetings moving forward. A lot of different solutions. If you think about, and we started talking about this back in Minnesota from my locale, and we're not any different. We're an upper Midwestern state. We're the largest sheriff's office in the upper Midwest. I went to Senator Franken and asked him for some help. We had some community roundtable meetings with providers, other sheriffs, other public policy makers on the federal, the state, the local level, and asked for assistance in trying to figure out, what should we do? What are some of the answers? We knew what the problem was. That was fairly simple. What we didn't know what were some of the answers. We did an exhaustive search of some of the research, the best research that was out there, and tried to come up with some solutions. The next one. All right. Well, in our research, we found that Minnesota led the nation's lowest number of treatment beds. Normally 50 is recommended. We came dead last at 3.9 per 100,000. You know what that means at the end of the day? You guys can be interactive. Now, come on. Are you shy? Introverted? You don't know what to say to the sheriff. Is that the deal? All right. Well, if you don't ask me, I'm going to ask you. She said it was interactive, so I'm going to put you on the spot if you don't ask questions, especially when we get down to the end, where I don't see some response from you. You think about this, right? 3.9 beds available for every 100,000 residents. It's not enough. And I'd venture to say all across this country, the other sheriffs like me, about 3,100 of us, all face the same things. The difference is we represent your jurisdictions, where your congressmen come from, your representatives, your senators, etc. Just like your neighbors and your friends and your family. And that's a problem for us. Go to the next one. All right? This is what it looks like. Now, there should be about 100 or so folks in this one pod of our jail. These photos obviously are staged, but how'd you like to be working in that setting, right? You've got the one deputy, really nice guy, Sergeant Jay Cox, but you also have 3 inmates there, and you've got another 90 or so inmates maybe behind the doors in the open setting. Just think about what happens to these folks in an incarceration setting. Just think about what I said before about the different noises and sounds and those jail doors clicking shut, right? And you got to follow the rules. You guys like following rules? Sometimes? Oh, you do, huh? Well, that's good. All right. Go to the next one there. These, some of the photos that I put up there that she's clicking through, we had our deputies participate in a national webcast. They demonstrated their de-escalation skills for the National Institute of Corrections, what we call crisis intervention teams, and he just referenced it. All of our folks who work in the detention setting at our jail, as well as our deputies who work in the courts, who work in our crime lab, who work out on patrol, who work in water patrol, who work in warrant service, who work in civil process, all go through crisis intervention training. Why? Because we think that although maybe the population of the folks who come to the jail is a little skewed, like I said, conservatively 30% of those folks come in with treated, untreated mental illness, and now we're faced to deal with them. We also believe that's generally true of the general population. And when you need help, someone's choking, there's a disturbance going on, maybe a traffic crash. You want our deputies, our police officers, our law enforcement professionals to understand those de-escalation techniques. And unfortunately, we come across a lot of folks. A lot of folks who had prior military service, a lot of folks who for some reason didn't get the medical assistance they needed on the front end regarding mental health. And now, at the end of the day, what do? Right? We're like the Maytag repairman. You call not 411, you call 911, and now comes a police officer, and now the police officer is going to deal with this situation. Unfortunately, they need the skills and the techniques and the tactics to be able to do so, and that's where these best practices come in. You go to the next one. Our crisis intervention training are effective, we think, in enhancing correctional staff's knowledge and our skills. Like I said, we aid administrators and improve management and care for this special population. Within my jail setting of about an average of about 900 inmates a day, I've got less than 40 beds set aside for those who suffer from the most severe forms of mental illness until they go to trial. Some are with me several hours. Some are with us for an average of 7.5 days. Others spend well over a year. As it stands yesterday morning, because every morning I get the count, we had 47 different people waiting in jail as a result of murder charges. And what do you want me to do with them? You want me to send them back to a hospital for treatment? You want me to try and confine them and detain them because they are a problem to the general public? My options are fairly limited. And go to the next one. We did this just a couple weeks ago. We've been working on this well over a year. Again, we went out across the country. We looked at other agencies, other cities, other locales. Some of them are yours. And said, well, what's the best way to deal with these folks? Crisis intervention training is certainly one. We also decided that our integrated access team might be another. So now everybody who comes into jail, you think about this. You come into jail, you come into what we call a sally port. So for those of you that haven't been to jail, maybe taken a tour of jail, usually you come into a big garage area and it's secure. Usually you're in the back seat of a squad. Only my friends get to ride in the front seat. So you guys would get to ride in the front seat. But usually you're in the back seat of the squad, you're handcuffed. You now come into a jail or a confinement type setting. And when you come out of the squad car, you're still handcuffed. We take a look and talk to you about your medical needs, right? You may have been in an altercation with someone before the deputies came across you. You may be just a little paranoid. You may have some anxiety going on, like the guy in the airplane yesterday on the way out here that was sitting next to me squeezing that water bottle as hard as he could. He had anxiety. And thank God it was just a water bottle he was squeezing. But that happens to people, right? I mean, people who come to jail come from all segments of the population, races, ethnicities, backgrounds. There is no one specific piece of it. But we look at them from an integrated access team approach. And We talk to them about, look, what's going on in your life? Now you've got this problem with HIPAA laws. And we talked a little bit about it earlier, right? I mean, do I get access to, if someone's been in the hospital recently, or one of our local law enforcement agencies has taken him or her to crisis or put a 72-hour crisis hold, do I get access to that information? Should I have access to that information? Was HIPAA ever meant to be a barrier for public safety to help us treat these individuals? I don't know. These are all great questions, right? Ask your sheriffs when you go back home. Ask your police chiefs and your local law enforcement. And go to the next one. You know, we don't think we're done by any means. Our integrated access team, our crisis intervention training, just a couple different aspects about how your local sheriffs across this country deal with those who suffer from mental illness. Now, once our court orders treatment for these inmates, we now have a statutory mandate for our state's Department of Health and Human Services that they must provide a bed and transfer within 48 hours. You understand what that means? So you get booked into jail for an assault, a burglary, a theft, maybe even some type of a drunken driving charge or something. And, you know, you're going to go see a judge within a short period of time, and the judge is going to say you are or are not competent of understanding the charges against you, as well as competent whether or not you should or should not stand trial. In some cases, the judge says, you know, you're in crisis mode and you need help and treatment. And so at that point, are you culpable or capable of understanding the criminal charges against you? And should you remain in a correctional setting, or should you get some medical assistance through mental health? Which one do you think it is? Which would you want for your mom or dad or brother or sister or niece or nephew? B? That's right. So, now what's my choices? I transfer to a hospital? I transfer to the state? They don't have any beds available. He talked about it just a few minutes ago. You know, a decade, 2 decades ago, we unfortunately reduced the number of beds. My state has 3.9 beds for 100,000 population. I should have about 50 beds per 100,000 population. My state's not any different than the states or the locales that you come from, but what we're asking is take a look at what's behind the scenes. Take a look at what's happening within your districts, within your individual states. Go to the next one. I think that's it. I'll leave it at that. I think hopefully pique some questions for you to ask at the end, since you're all pretty shy here. And then we look forward to a good, robust discussion from a panel perspective. Fair enough? All right. Thank you. Sarah?
All right. Yeah. Glasses. All right. Thank you. So as Christine mentioned, I'm from the University of Washington, so I'm feeling very at home today with this rainy day. Ironically, I think there's actually sunshine in Washington State. I'm going to be talking about implementing evidence-based programs, which are clinical programs designed to help youth with behavioral and emotional disorders who are involved in the juvenile justice system, as Joe referred to. And I'm going to do it in the context of a case study of what's been going on in Washington State, give you an idea of how it's worked there, our successes and lessons learned. Slide. So Washington State's experiment with evidence-based practices started in 1997 when the Community Justice Act was passed. And this act was a response to what had been increasingly punitive policies towards juveniles who were committing crimes. So as Joe alluded to, there was this big peak in juvenile offending in the early 1990s, and a lot of states started passing laws that were increasing juvenile incarceration rates, trying more juveniles as adults, and that same thing was happening in Washington State. And administrators and policymakers realized that wasn't going to be a sustainable policy. One, it was too expensive. The daily population rate in our juvenile facilities doubled during that time. It was incredibly expensive to keep kids in those facilities. And we had too many kids going through adult courts. So amongst other things, what this act did is it created an advisory committee, which is called the CJA committee, which is the Community Justice an Accountability Act committee. And they were in charge of selecting the community-based programs that would be eligible for state funding. And one of the requirements is that these programs had to have some evidence, some research evidence behind them that they would reduce delinquency. And so the Washington State Institute of Public Policy, which if you had been in previous presentations may have been mentioned already, did a comprehensive review of programs that had been tested for delinquency and created these cost-benefit estimates. So what they did is they looked over all the studies that had been done on a particular program, and they took the average impact, and then they developed a formula to look at how much would taxpayers save if this program was implemented. So using that information, the CJA committee ended up selecting 4 programs: functional family therapy, aggression replacement training, coordination of services, and multi-systemic therapy. Functional family therapy is a family-based intervention that focuses on reducing conflict in the home and increasing parental skills around monitoring. Aggression replacement training is a group-based intervention for kids who need some support around emotion regulation, problem solving, and moral reasoning. Coordination of services is a diversion program, and multi-systemic therapy is a very intensive intervention that works with kids in multiple systems around their school involvement and engagement, around family and other community services. So these numbers here are the number of counties that implemented these different programs, 14 with FFT. The most widely implemented program was aggression replacement training because it was the least expensive, and relatively fewer with the others. Next slide. So as you can see, this slide illustrates the fact that the juvenile arrest rates in Washington State have gone down precipitously since the implementation of these programs. Now, the national arrest rate has gone down. The national arrest rate has decreased by about 30% since 2000. In Washington State, the juvenile arrest rate has gone down by 47%. And I think rightly so, it's interpreted as a success of the implementation of these different programs. I also want to mention that our juvenile incarceration rate has also gone down quite a bit. So we went from a daily population of 1,000 youth in long-term care to now it hovers around 600. So consistent with the around 50% decrease that Joe was mentioning in incarceration rates. I didn't do a slide on it, but there's a note on it in your facts. So I want to also mention that in Washington State, our long-term juvenile incarceration facilities have a therapeutic treatment model. It's called the integrated treatment model. About 60% or more of the kids who end up in long-term incarceration in Washington State have diagnosable mental health disorders. And so they've implemented a therapeutic program that is a combination of different therapeutic clinical techniques around emotion regulation. And research that I'm doing right now with the National Institutes of Justice grant is showing that most kids come out of those facilities with improved skills around problem solving, life skills, and emotion regulation. And that these skills are really important and impact whether a kid will reoffend. What is not important is that they stay a long time. So this will be used to sort of look at policies for how long youth need to stay in these facilities. Next slide. So Washington considers the implementation of evidence-based practice to be a big success, but it's learned a few things along the way. One is that it really, really matters how these programs get implemented. So research that was done on all of these programs in Washington State, again by the Washington State Institute of Public Policy, showed something that was a little alarming. The good news is that when these programs are implemented as they are intended to be implemented, with fidelity or adherence or some of the words that we use, and the therapists that are doing the work are competent, you see big reductions in juvenile recidivism and these kids don't commit more crimes. The concerning thing is that if kids get these programs and their therapists are not competent, their outcomes are even worse than if you had not done anything. So our policymakers are faced with kind of this interesting conundrum, which is if you do it poorly, you can actually make things worse. So it's really, really important to do it well because then you'll make it much, much better. As a consequence of finding this out, Washington State is now invested in quality assurance infrastructure. So there are now quality assurance specialists that work with all of the therapists and group facilitators that are implementing these EBPs to ensure that services are being implemented in a competent way. Next slide. Oh, it's a moving slide. So go ahead and just click through so all those come up. The other thing that's been important for Washington State is lessons around the effectiveness of these programs with subgroup populations. So we know that these programs work in the aggregate, but how are they specifically working for different ethnicity groups and for gender? Again, these are results from the evaluation of FFT, looking at their effectiveness with ethnicity. And what's interesting, if you look at the results to the left of the white dotted line, it looks like actually minority youth are benefiting from the programs more than Caucasian youth, which seems fine, which is good, right? If you look to the left of the line and you break down ethnicity a little bit more, you actually see that the recidivism rates, which means the reoffense rates, for African American youth are higher. And much of that reduction is being driven by the success rates of Asian American youth. So these things are important because they help us try to think about what populations might we need to be thinking about improving the efficacies of these programs with. Mark Lipsey is really renowned in the field in looking at the effectiveness of delinquency programs, did a meta-analysis with some colleagues looking at across many, many, many delinquency programs, how they fare with minority populations, and found that in general, they work just fine, which is great, really encouraging news. So the recommended strategy should be that we continue to do these programs with all populations. But the thing that's also a little concerning is that on 7 out of 10 of the outcomes that they looked at, minority youth didn't fare quite as well as Caucasian youth, even though in general they were improving. So what it suggests to us is that you should do them. You should definitely do them across populations, but we need to be looking at ways to make sure that those outcome levels are equal across populations. And then next slide. The other sort of subgroup that's really important to think about is how these are working with girls versus boys. So most of these interventions were initially developed with white male juveniles, and it's been a little bit of a learning process seeing how they work across different groups. And there's some mixed findings around how they work with girls. Girls in the justice system, I'll just mention briefly, are probably one of the most vulnerable populations in the United States. They have the highest rate of psychiatric need compared to boys in the system and girls who are not in the system. They have the highest rates of sex abuse, and they have the highest rates of running away. They're the most likely to be on the streets without any support or services. So there's some unique things that we need to think about when girls are involved in the justice system. It's not all girls who have those histories and risk factors, but a greater number of them do than boys in the justice system. So a few things that we know about girls. We know that they drop out of services at a higher rate than boys do. They're not being engaged as successfully as boys. With functional family therapy, there's some mixed findings on if it works as well with girls than boys. One study found that it didn't. Another study found that it did in some domains and not others. Multisystemic therapy looks like it works just fine for both genders, which is really encouraging and great to know. So as a response, go ahead into the next one, to some of these largely encouraging findings, but some areas where we feel like we could be doing a better job with different subgroup populations. Washington State, we've been embarking on some cultural enhancements to programs. And so far we've developed cultural enhancements to some of our co-occurring interventions for Latino immigrant youth, and currently working right now with 6 counties on developing cultural enhancement to aggression replacement training for girls to see if we can increase those engagement rates and those outcomes. This slide just kind of presents the results of a large review of mental health interventions and cultural enhancements and adaptations, and found that when you do cultural adaptations, you improve engagement, satisfaction, and outcomes. So it's an important thing to have in our toolbox when we think about disseminating and implementing these programs across different groups. Next slide. So just in summary, Washington State has found that they could not afford to not invest in evidence-based programs. If they hadn't invested, they would still be seeing very high juvenile arrest rates, and they would still have very high rates of juvenile incarceration. But that also these programs need to be implemented with quality and fidelity. There need to be investments in quality assurance infrastructure. That engagement and effectiveness is going to be heightened when we pay attention to culture and implementation across subgroups. And the last point I want to make, which I think is one that Richard and Joe both made, is that the best way that we can avoid costs and juvenile crime is if we can start investing in effective programs in mental health systems and child welfare systems. These are huge feeder systems for the juvenile justice. And if kids' problem behaviors can be addressed there before they do something really bad, we won't even need to think about intervention at this level at all. Okay, thank you.
I'll just turn the mic on. So we'll just take a few questions, and then I highly encourage you all to come up and speak directly with our panelists as we conclude here. But just to jump back for a minute, during Joe's presentation, he mentioned a series of Supreme Court decisions that have come out really relying upon a lot of this adolescent brain development research that has developed over the past decade. And in our next briefing on November 21st, we will actually be bringing in some of the top legal experts from across the country who have both been engaged in a lot of those cases to really kind of walk through what the decisions were, as well as the implications of the cases that Joe mentioned, not just in terms of the legal outcomes, but how that is being infused into a lot of practices at even some of the local level. There are jurisdictions in the country that are actually now training their local police officers on adolescent brain development research along the lines of what the sheriff described around different types of training. And the other thing I just wanted to mention to pick up on Sarah's final point is that we're then going to have a session in January to really drill down on the complexities of some of these system issues in terms of the intersection between the mental health system, the child welfare system, and the juvenile justice system, as well as the adult criminal justice system. It's a really complex area because these are all bureaucracies that operate in various ways, both at the federal, state, and local level. And so we want to spend some substantial time talking about that as well. So before we turn to some questions from all of you for our panelists, the one other thing I just wanted to make explicit, as I'm grateful for all of you joining us this morning for this conversation, is that Joe said directly in his remarks, and I think as was implied by the other panelists, there's a real tension here in terms of who are these young people and adults that are coming into contact with our justice system who are suffering from mental illness. And as Joe and the sheriff described, there has been an evolution in our country, and that there was a whole wave of an effort with very good intentions to deinstitutionalize individuals with mental health issues and to bring them back into our communities. And that was done in the spirit of trying to find ways and supports for individuals who are functioning to be part of our communities. And I think it's really important to emphasize that not all mentally ill people are violent. We know that with treatment that a lot of people can get a lot of strong supports and be very highly functioning and productive members of our communities. At the same time, what Joe said, and this is, I think, really hard to believe and it's sort of hard to digest, is what kind of situation would prompt a family member to seek justice system involvement in order to seek health care for their person in crisis? And another part of what happened in this country over the last decade is that, the mentally ill rights or mental health community sought very hard to see rights for individuals with mental illness. And often what happens during a period of crisis, and especially for young people or for perhaps someone who's first discovering or having their first symptoms of a mental health crisis, they have a right in their own healthcare choices to decide whether or not they want to seek treatment. And so in those moments, often when a person is and hopefully for many of you, this isn't only a situation that you've seen in the media or perhaps through news reports, when that person's at the state of most extreme psychiatric crisis, they may not be able to see the need, and they may not make a decision to seek appropriate healthcare treatment. And I wanted to pause for a moment to talk about this because a situation that I don't disclose publicly, but I think is relevant to this conversation this morning, is that when I returned to work on the House Judiciary Committee in 2003 after going to law school, I would come to work every day and I would do what many of you do, which is to deal with whatever my member of Congress's priorities were for the morning and the afternoon, and often very late into the evening. And during this time, my mom also went into a mental health crisis. She had had earlier symptoms, but for the first time in her life as an adult, she ended up in a state of complete psychiatric disorder, and she was not able to make decisions for herself. So here I was working for a member of Congress. I'd gone to law school. I thought I was somewhat savvy about how to get her help, and I couldn't. And ultimately, a situation that escalated very quickly and very intensely in a community that she was living in Maryland, as Joe described with the $20 bill, I found myself having to seek law enforcement intervention in order to get my mom health care. And, it was probably, one of the worst experiences I have ever had to go through as both a child, helping a parent with a healthcare issue, but also just living in this country and realizing that that was the choice that I was going to have to make. And, I think I disclose that to all of you to just emphasize that it is very easy, I think, when we're talking about all of this, to sort of assume that something's gone wrong in this kid's life, or the parents aren't making the best choices, or the kid's done something really dumb. But at the end of the day, when we talk about this subpopulation coming into contact with the justice system, in more instances than not, it's not the first choice that the family or the young person's making. It's, as Joe said, it's the last resort. And so I think it's really encouraging, as Sarah and Sheriff Stanek have described in great detail, as well as in Joe's remarks, that we know a lot more than we knew even 10 years ago, and arrests are going down and populations in detention are going down. But at the same time, I think Sheriff Stanek's op-ed really kind of highlights the whole issue that we're trying to talk about today. Is jail or a detention facility really the right place for a mentally ill person? And so with that, I wanted to just ask our panelists to talk a little bit more about their experiences. Joe, you talked a little bit in particular about the impact that trauma has on a young person, but if each of you could just say a little bit more about why it has an impact, because I think we have a gut reaction that trauma could have a lifetime impact on an individual. I can certainly tell you that my experience with my family has made a huge impact on my professional choices for the rest of my career, as well as a lot of my personal views on these topics. But I wanted to let Joe speak a little bit more about what he's learned through the research.
Let me just talk for a second in terms of, this was actually a couple weeks ago. I was at a meeting of something called the Council of Juvenile Correctional Administrators, which is all of the commissioners, directors of all the state agencies from across the entire country. And trauma was actually one of the big issues on the table. We spent a considerable amount of time talking about it, getting feedback. Is that okay? And I think, again, what we're beginning to understand is that when you take kids, and again, the rate for the kids coming in the juvenile justice system is much higher. Again, I had some numbers up there, both in terms of the proportion of them, the percentage, but also the number of this something called Adverse Childhood Experience Scale that was developed with ACEs. You may have seen something about it. And it counts how many bad things have happened to as a youngster in terms of abuse, exposure to murder, all of those kinds of things. And the kids in the juvenile justice system come up much higher than other people in the population, not surprisingly. And I think part of what's happening in the justice system is trying to understand both how that relates to other issues like mental health and substance abuse, but what they ought to or not ought to be doing within their own system. So if you think of a young woman who's been sexually abused and is in a juvenile, this is one of the examples they talked about, and is in the juvenile justice system and starts acting out, and there are two males that take her down and hold her down, it's re-traumatizing, adding to the problem rather than helping the problem. One of the things that's just amazing is to sit, again, when you think of correctional people, most of us think about these hot-ass, tough, by the law, don't be too nice to any of these kids who have been involved in some crime. And the other major issue, then we had the administrator from OJJDP, Bob Listenby, was at the meeting, and he headed a panel on how can we get rid of isolation? How can we decrease the use of isolation? And again, when you think about it, I've been in facilities where you walk through and they have kids who are acting out, and they put them in these little tiny rooms with glass windows, naked, inside the room, with nothing happening to them. Now, there's been adjustments in terms of now most places will mandate somebody walks by to take a look at it. But I think there's growing realization of the importance that it plays, but also that the justice system often exacerbates it and re-traumatizes the youth, and we need to figure out better ways of dealing with those kinds of issues.
Well, so the question on the table is what? I mean, what do you want to know?
Well, I'm curious from your perspective. There's new research by the Arnold Foundation that I think confirms what a lot of people might have suspected, but is now available through a lot of work they've done, that the impact of arrest in the trajectory of an individual's life, in and of itself, regardless of what happens next and whether or not they're convicted of a crime, that trauma from that arrest can actually impact people's future events, both in terms of future contact with the criminal justice system or whether they end up being productive members of our society. And so I'm just kind of curious from your perspective and the experience that you've had. Certainly, these are decisions that have to be made in the heat of the moment for a lot of your members of your sheriff's department. How do you reconcile how to respond to a situation of crisis while knowing that it could create trauma for some of these individuals?
The question cuts across a number of different issues. Now, we always say at the end of the day that, I'm the guy you pay later. You're either going to pay me on the front end by investing in young people and mental health treatment, whether in the school setting or trying to identify what issues are going on in the home, whether it's kind of that holistic approach, or you're going to deal with me on the back end. Because eventually these folks are going to end up in our jails, and they're going to end up in prisons, and they're going to end up committing crimes, sometimes through fault of their own, sometimes not through fault of their own, but I'm the guy you're going to end up paying later, right? And so if you keep that in mind, when someone gets, we see this time and time and time again, young people, folks out on the street, they are in mental health crisis. They've got issues going on, again, whether personal, family, whatever issue might be, and they end up acting out in some way or form, sometimes in and of themselves, sometimes they act out because it doesn't meet the standard or the norm in which they're doing this act, right? It could be, we always say downtown Minneapolis, just like downtown any city, anywhere across this country, someone that's out because he or she is homeless, they're incorrigible at home, they've had a fight with their parents, they end up out on the street for whatever reason, and now they've got to survive. So how do they survive? They may beg for money, they may panhandle, they may even shoplift at a store. Eventually they're going to come in contact with the criminal justice system, and it continues to exacerbate the condition by which. And then you get into this revolving door piece. You've heard that phrase before, right? About 70% of the people, 70% of those 40,000 people who come into my jail are repeat offenders. They've already been with us before, many of them because of these low-level misdemeanor-type offenses. And, at some point you've got to stop and say, okay, now why are they coming to us? That's why we talked about our integrated access team approach. And that's why we talked about I'm the guy you pay later. We partnered with other agencies, with other services to try and figure out what's going on in their life to intervene, maybe divert them from the criminal justice system when absolutely appropriate. There are some, as the doctor said, where it's not appropriate. If you commit a murder or you commit a violent crime, you're going to have to be held accountable at some point for the crimes that you committed, and then they're going to deal with it. But there's others on the front end that we should be dealing with, whatever issue got you into trouble with the criminal justice system to begin with. Not an easy thing to do. What I do know at the end of the day is that the law enforcement folks in this country, all 800,000 of them, should not be dealing with them, right? We have a set standard way in which we deal. We are compassionate. We treat people with dignity. We treat people with respect. But you also have societal norms and expectations called laws and policies and procedures that you put on your local law enforcement by which to enforce, and you expect that we enforce it. Okay?
Thank you. Sarah, you have any comments?
Yeah, just a couple. Oh, am I on? Okay, a couple thoughts. So I think trauma is often used as a fairly umbrella term for a lot of different things, some which have more specific definitions. So as Joe mentioned, ACEs are sort of a number of adverse experiences that represent accumulating stress over time that can be related to a lot of negative outcomes. What you were mentioning about arrests and early contact with the system, those are negative for youth because they lead to self-labeling or peer contagion. Then they're around youth who are doing more delinquent things, and so those youth start doing more delinquent things, or they suddenly think, oh, I am a bad kid, because adolescence is such a prime time for identity development and formation. Trauma as a specific kind of clinical term means when somebody has had an event where they've feared for their life or serious physical safety, or they've observed somebody else experience that. And huge numbers of kids in the justice system have had trauma at that level where they've really feared for their life or their physical safety. And we know that sustained trauma over long periods of time can actually create cognitive changes so that they perceive the world differently and they process information differently. That has implications for the safety of the officers and the probation officers and detention officers that work with these kids. A lot of these kids develop a style of interacting with the world that is reactively hostile, which means they expect bad things to happen to them, and so they act in ways that elicit those behaviors. So they are often very hostile, or it can be interpreted as manipulative or non-compliant. That's been their experience in the world. They've been re-victimized so many different times that they have to adopt those behaviors to what they believe to keep themselves safe. So when officers are not aware of that and they engage in sort of power struggles with these youth, it impairs their safety and the safety of the youth. The other thing is just effectiveness. If we can develop strategies for working with youth that disengage power struggles and work towards youth strengths and youth goals, we're much more likely to be effective and is a more effective trauma-informed approach. Some thoughts?
Well, I think especially that last point in terms of looking forward for ways that there can be an investment made into some of these trauma-informed approaches would hopefully yield significant outcomes to make sure that while we need to make sure that there's adequate resources and investments in our public safety systems, as the sheriff said, at which point do you want to invest and at what measure should the investments be allocated in terms of proportionality. We'll open it up if anyone has any questions at this time, or if you prefer, we can also pause, and I certainly welcome you to all come up and talk with our panelists. As I said, one of our goals for this series of briefings is really, on behalf of Vera, to have this opportunity through the support of the MacArthur Foundation to bring you into contact with some of the leading voices and actors on these issues across the country. As I said, we'll have our next gathering in November on the lawyer's role in youth justice, and then another session in December on family engagement with the juvenile justice system, at which I think a lot of these same themes may come up again. And I think just overall, as our panelists mentioned, one really encouraging trend that I think we have a lot of literature outside that discusses in great detail, but that also, as the sheriff said, you can learn more about in terms of your local communities, is that I think that there are a lot of developments that have taken place in terms of research-informed practices in a lot of these jurisdictions. And as Sarah went through in great detail, different states such as Washington have actually then gone and evaluated the impact of some of those approaches. We still have a long way to go, but again, I think that we're at a juncture where more investment and consideration of those types of approaches may bring us to a point where Joe and I and the others have fewer conversations around this topic in the decade ahead. So thank you all for joining us, and we look forward to seeing you at our next briefing in November. Thanks.
I'm going to leave some business cards up here. If any of you, I know you're shy this morning, but if you choose later to give me a call, I'll give you a quick call back and answer your questions or point you in the right direction from what I had to say. Okay?
Oh, sure. Question.
My name is Michelle from Anderson Lee, and I live in Congressman Shop Matara, who's at 39, ranking member of the Congress Justice Science Appropriations. And I wanted to ask about the effect of, or how many of these youth are you finding that are actually have been in the foster care system?
And I think, did you have a session on that already? Or
No,
you're
it's
gonna
coming
have
up.
one? Coming up. She's doing a nice job with all the teasers out there, isn't she? It's a very high proportion. I think it's like 40 to 50% of the kids have some contact with both systems. So it's a major issue causing a lot of confusion at the local level in terms of who has responsibility, sharing of information, a whole variety of those kinds of topics.
Well, we can follow up with you after the briefing, Michelle, with some more specific documents around that. But as Joe said, I mean, we do know that. At the same time, one of the inherent challenges in a lot of this work is the data collection piece, as the sheriff alluded to, in terms of sharing of information. So there is more knowledge about this, what we call kids who may be crossover, going from one system to the other. At the same time, in smaller jurisdictions, if they don't have the capacity to collect that data, or if the kids move around, it's, in some ways, we may have completely underestimated some of the parameters of those challenges.
Just one thing I want to add, because that's, in doing the work over the past 8 years or so with MacArthur, what they've tried to do is to address issues as they've come up and they've seen to be systemic problems. And so the whole sharing of information has been a major issue. And they have, if you go on the website that I put up there earlier, they have a great piece that they put out on information sharing that basically talks about the laws, talks about models for doing information sharing, has practical examples, and I think comes with a CD that you can actually take and run through and use. So there's a lot of that kind of help is out there at this point.
I might just mention, this is out on the tables. It talks about some of the prevalence rates. Actually, I think the study was in King County, and they showed that there was 67% of the kids in the justice system had had an open child welfare case at some point. Those weren't necessarily active cases, but it was a huge number that had some involvement.
Can I also ask, what percentage do you think came from single-parent households?
I don't know the number. Again, that's just a reality of the world at this point. I think earlier on that was seen as major variable in terms of its impact on youth. At this point, that's such a large proportion of people that I think it's just a reality that we're all dealing with.
Go ahead, Connor.
So, you got a quick question about here on Capitol Hill, obviously. I'm Connor, I work for the Charles Group, policy shop here in DC. Your answers may be all different on this question, but we're up here on Capitol Hill. There may not be one easy solution, but we are looking at a new Congress here in the next couple of months. What can Congress do on these issues? I know there's some legislation that is pending. There's obviously not going to be a one-size-fits-all approach, and something may not address all of the issues talked about here today. But if there's one thing that Congress can do, maybe it's a reauthorization of a particular program that would take care of a few of these things, or maybe it's funding of a particular program of some sort that's maybe been lagging for a while. I'd like to get your thoughts on maybe what Congress can do to sort of alleviate some of these problems.
Go ahead.
Yeah, and there's a couple of things. Again, part of what I think is important is getting the services to the kids as early as possible. And so, you know, when you take a look at the violent incidents that have occurred, there have been all kinds of, there's so few cases, there's always different kinds of explanations. But in almost all the cases, there was some early sign and some potential ability to get them the help early. And within the country, mental health services for youth is second citizen. Okay, most of the state agencies focus primarily on adults in terms of their priorities and in terms of their funding stream. So you have control over the resources going to mental health. Anything, not you personally, but anything that you can do to encourage that, it certainly would be helpful to get those services to youth as early as possible and to link to the programs, particularly around the juvenile justice system, some of the ones that I described. The other piece which relates to that is collaboration. So, for example, there's something called the Justice Mental Health Collaborative. When it originally passed, it was called MIOTRA, Mentally Ill Offender something. It's Treatment Crime Reduction. And that's one of the places where there's already some stream of funding out there. Typically 20% of that goes for kids. And again, I'm not saying it ought not to go for adults, but in terms of getting them early so they don't end up later on in the system, it would be nice to see a greater emphasis on services for youth, but with a particular emphasis on diversion. Right now, it kind of funds anything in the area. So I think there are opportunities that are out there.
Sheriff, do you want to add something?
I think it's helping, inspiring, coercing the states, whatever way that process would be, to provide community mental health beds. Because these folks suffer from mental illness. They're going to end up in the system, the criminal justice system, at some point. And our job is either to divert them before they ever get there, or once they're there and they're not capable or incompetent of standing trial, to put them back out in the community where they can receive the medical help they need, not the detention help that the jails provide. There are some people who belong in jail. There are many who shouldn't. And unless something changes, our jails across the country will continue to be the largest mental health warehouses out there. And that's not what you designed the criminal justice system for, your members.
Well, you mentioned reauthorization. I think the Juvenile Justice and Delinquency Prevention Act would be helpful. That would provide more resources for states who wanted to do these kind of policy and program reforms. I'll also mention that we run into barriers with implementing these programs because folks can't bill all the aspects of evidence-based programs through Medicaid reimbursement, particularly the needed elements around sort of quality assurance and training workforce. If there's a way to think about increasing kind of billable codes for those kinds of activities, that would really help, particularly would help on the mental health side. And I also think strategies or incentives to get our mental health system thinking a little bit more about violence prevention as a part of their routine work would help. It's not something that is typically or often in their purview, but if they could be focusing more on violence prevention programs and activities, I think we could keep more of these kids out of the justice system.
And I'll just add specifically, because the example came up in our panelist presentations this morning, the Justice Mental Health Collaboration Act that Dr. Kokoza mentioned did provide the original authorization for local law enforcement agencies to do the crisis intervention training. And so that continues to exist. I don't think it has an explicit provision in the original authorization or the subsequent reauthorization around training for youth. But as Dr. Kokoza described, I mean, that is also another area where there is a system in place, but like everything else right now, there are certainly more jurisdictions seeking awards and support for that type of funding than has been available under the existing appropriation. Any other questions? Go ahead in the back.
I know that best practices, particularly in the state of Washington, were mentioned in how the fidelity that a program is executed is really important to its success. And I was curious as to, for instance, how competence is measured among therapists, because that was mentioned in particular, as well as what are some of the specific quality assurance checks.
Yeah, great question. So I'll use aggression replacement training as an example. So they hired a quality assurance specialist who developed session checklists for all of the group facilitators. They have to fill them out after every session. So what it does is it provides not only a way for them to self-rate, but it's a continual reminder of what they need to be addressing in sessions. And then they do regular in-person observation of the sessions where a consultant expert actually goes in and looks at the quality, and if there's any kind of needed coaching, then they'll do that work. Additionally, people have to go through an intensive training before they're allowed to do aggression replacement training, and they have to do some skills demonstration before they're allowed to then work in groups. And then typically they are paired with someone who's more seasoned. And so that's their kind of process for quality assurance. And they've also shut down groups when if they feel like kids are not engaging, because the risk of group-based treatment for juveniles is that you can have that peer contagion effect. You don't want kids getting all sorts of ideas about how to do bad things. And so you have to be very structured and monitored. And so they'll actually monitor for that, and they'll actually stop groups if they feel like the kids aren't getting the benefits. So that's one example. I'm happy to talk with you more about other ways these programs are being monitored.
Well, and I think to Sarah's point, I mean, this is another area where there is a real change going on, and that for a long time, a lot of these programs went on without a lot of evaluation of their effectiveness or their impact. And so I think that's another role that the Congress can play in terms of looking at which approaches have shown the best results, but then also in instances where there are approaches that have not been shown to have effective outcomes, I think there's still a question why some of those practices continue. So again, I think, we know a lot more than we did a long time ago, and as Dr. Kokoza alluded to in his remarks, we are now sort of what a lot of the folks in the field are describing as a fourth wave around approaches to youth coming into contact with the justice system. So there's a lot of opportunity to use the research and developments in a lot of these different state and local jurisdiction practices to inform federal leadership in this area. So again, thank you all for coming. We hope to see you again in November. And of course, in the interim, if you have any questions for us or for any of our panelists, we're happy to put you in contact with them. And thank you again for the interest in this important topic. Thank you.